And good morning, and welcome to Internal Medicine Grand Rounds. I'm Dr. Anil Williams, Chair of Medicine here, and we are so pleased this morning to have what I'm really looking forward to as a discussion of lung transplantation as a therapy for advanced lung disease, the past, the present, and the future. It's going to be given to us by Dr. Anil Trindade. He's an associate professor of medicine and associate medical director of the lung transplant program at Vanderbilt University. And to give him a proper introduction, we have our chief of pulmonary medicine, Dr. Mohammed Saad, who's been an amazing leader. Sometimes people just work so hard and do everything they should, and they're just a pleasure to have as a division chief. And I inherited him, and I do everything I can to support him because he's got tough stuff to do, and he's doing it so well. And I know this is a little unusual, but would you just mind giving an applause for Dr. Saad? In critical care. Thank you so much.
Thank you, Dr. Williams. Appreciate it. Thank you. Good morning, everyone. It's a real pleasure today to welcome Dr. Anil Trindade from Vanderbilt University. If you look at his CV, it's amazing academic accomplishment and career. Did his medical school at Duke and residency at Johns Hopkins, and went on to do the not traditional, but the typical scientist route with 4 years of fellowship at Harvard. Ended up staying there for 2 years, post fellowship, and then 1 year at Tufts. Went to Columbia, back to Harvard again, and came to, of course, Tennessee in 2019 as an assistant professor. Been there for 6 years. Currently, he's an associate professor there and associate medical director of the Transplant. We were just talking last night, of course, about the growth of his program. When he joined, he used to do like maybe 25 cases. Now they are up to 110 and up maybe projected 135. They are the second in the nation as far as volume. And of course, if you look at his resume, numerous publication, lecture speakers and national and international meetings, very well known. And I wanted this to be given by someone like him because we want to, of course, work on making the internal medicine understand principle, lung transplant, when to refer, understand this concept. We have tremendous program here with Dr. Alan Ramirez and Dr. Alex Ng, and they've been doing a phenomenal job with our size. We were just talking last night. We did 25 cases last year. We probably projected to do the same number, maybe a little bit more this year. So I wanted this to be an important topic for you guys, for the Department of Medicine, to understand transplant. And no better person to present this than Dr. Anil Trindade. So thank you for coming, and welcome.
Well, good morning, everybody. Thank you so much for the kind introduction. Thank you to Dr. Ramirez for the invitation to speak today. He's been a wonderful colleague and partner for the last 5 years. Thank you, Dr. Saad, and thank you, Dr. Williams. So over the next hour, we'll be talking about lung transplantation. I think for those who might be thinking, well, this is a fairly niche topic, I would really make the argument a lot of what we've learned in the lung transplant field is really applicable to other organs. So kind of keep things with a broad context and apply it to whatever organ of choice that you might have a proclivity towards. So before I begin, these are my funding and disclosures. Nothing that I'm going to be chatting about today poses a conflict. So because this is Medicine Grand Rounds, I think we'll start off with a case that highlights some of the concepts that I'll be talking about a little bit later. We'll then chat for about 10 minutes about lung transplantation in terms of its history and how over the last 40 years or so, it's really become a bona fide therapy for patients with advanced lung disease. And then we'll briefly talk about some of the issues that face our field and our patients in terms of ensuring long-term allograft health. We'll then spend about 10 minutes talking about when to refer patients. So patients with advanced lung disease, specifically those with interstitial lung disease and those with COPD, when you're seeing them in your ambulatory clinics or on the inpatient setting, when should you think about referring them for lung transplant? So Dr. Ramirez is happy to help you get more referrals. And then if we have some time, we'll talk about some of the exciting things that we're doing from a research perspective to improve and enhance the field of lung transplantation right at Vanderbilt. So to start, I had the pleasure of seeing Biz. She's a 24-year-old female. Saw her about a year ago on the inpatient setting. She was a non-smoker, is a non-smoker, and had a history of maybe mild exercise-induced asthma. She had a Symbicort inhaler that she could never find, and that was basically the crux of her issues. However, prior to her admission, she started to have progressive dyspnea on exertion, and that was generally getting worse over the last 2 months prior to her admission. And then she ultimately couldn't take it anymore, was admitted to the emergency department, and that's when she was found to be hypoxemic, 78% on room air. So I just wanted to take a pause a little bit, since this is, again, medicine with grand rounds, and talk a little bit about my differential diagnosis for dyspnea, right? Because that's something that you guys commonly see in the emergency department as well as in your clinics. And normally I would pick on people, but I'm in a friendly mood, so I'll just start. So obviously, I think when most people think of shortness of breath, the organ that they kind of hone in on is the lung, and rightfully so. And remember that the lung is broken up into 3 main components. So you have your airway-centered diseases, things like asthma and COPD. So maybe not COPD in a 24-year-old, what we would think about. We certainly have parenchymal lung diseases, your diffuse parenchymal lung disease or your interstitial lung disease. Again, something that we don't always think about, especially in a young person, but maybe we should think about it a little bit more. And then certainly pulmonary vascular diseases, so things like, pulmonary hypertension and different flavors of that, and that's a whole lecture in its own right. Of course, we can't forget the heart, and so certainly diseases of the heart can contribute to shortness of breath. So, our left-sided cardiomyopathy, so both systolic dysfunction and diastolic dysfunction, perhaps not what we would think in a 24-year-old, but possible. There are valvular diseases of the heart, so perhaps she had some congenital abnormality that was missed. Arrhythmias and certainly, again, pulmonary hypertension leading to cor pulmonale or right-sided heart disease also makes that list. And then there are things outside the thoracic cavity that can contribute to shortness of breath. So musculoskeletal illnesses, hypothyroidism is something that you should think about. Advanced liver and kidney disease can certainly cause shortness of breath. Certainly in a young woman, anemia should be on your list. And then just for kicks, certainly psychiatric illnesses can present with shortness of breath. Now remember, she's not only short of breath, she's also profoundly hypoxemic. So I think it's important that we keep in mind some of the causes of hypoxemia. Again, this is a whole lecture in its own right, but I think we can spend a minute talking about causes of hypoxemia and how it pertains to Biz, our patient. So certainly, one of the leading causes of hypoxemia is mismatching in terms of ventilation and perfusion. So on your right, you have an example there of physiologic dead space where there's alveoli that are ventilated, but not well perfused. And then on the other extreme, you have examples of shunts where you have an alveolar filling process, or so consolidation or atelectasis, but there is still blood flow to that area. Also on the spectrum of EQ mismatch are impairments in diffusion capacity. So things that we generally think about, so thickening of the basement membrane, or destructive diseases like emphysema, where you're actually losing alveolar tissue and therefore have decreased surface area for gas exchange. Other things in the differential that might not be so apropos to our patients. So hypoventilation, things like central apneas. So Dr. Saad's a sleep doctor and sees this. So this is actually an image portraying Undine's curse, which is a quite famous painting there. Certainly in Nashville, where our elevation is about 550 feet, we're not thinking about low-inspired FiO2. And then one thing that I always teach my residents and fellows is when you have issues of low saturations, make sure that you don't have hemoglobinopathy, so especially methemoglobin. And again, nothing in her history would suggest that. So now that we've kind of narrowed our differential in terms of probably something dealing with the lungs, and probably something having to do with VQ mismatch and diffusion impairments. Now, as we take a history, we can hone in on some of those diseases that can lead to those things. So when we were chatting with her, she really didn't have too much in terms of her pertinent positives and negatives in her review of systems. So no fevers or chills, really no signs of any infection. She hadn't traveled anywhere, no hiking or camping. No issues with blood clotting or miscarriages. She did, though, have some occasional myalgias and arthralgias that were fairly diffuse, so bilateral, both upper extremity and lower extremity, although it was a little odd in presentation in that 1 week she would have some issues, then for a couple of weeks they would disappear and then return. As I mentioned, no significant past medical history except maybe some mild asthma. She was single, didn't have kids. She still lived with her parents. She enjoys crocheting and her dog Reba, after Reba McIntyre, and certainly no substance uses or abuses. Family history also not fairly contributory. I mean, her mother did have COPD, mild COPD, but not a genetic type like alpha-1 antitrypsin. No allergies. I mentioned her medications that she didn't really use. And then this was her exam. So I think the most notable finding is that she was profoundly tachypnic. So respiratory rate of 32, right? Remember, normal respiratory rate around 8 to 12, not the 20 that's documented in most charts. And then profoundly hypoxemic. So at this point, when we saw her in the emergency department, requiring high flow nasocannula, what we call OptiFlow, 70% FiO2 delivered at 50 liters a minute. And then the other notable findings, just crackles biobasally extending halfway up the lung fields, and then mildly decreased strength, actually, which was a little surprising for a 24-year-old. This was her chest x-ray. And again, I won't pick on anybody unless we have volunteers who want to read it. Okay, no volunteers. So just basically bilateral diffuse reticular. So reticular meaning lace-like opacities, right? And what you're missing here are, you don't really see profound consolidations. You don't really see air bronchograms. What you do see, though, are these tiny little holes there. And those are your small airways that are actually being stretched open. So bronchial ectasis that you can actually see on a chest x-ray. And then this was her sample sections of her CT scan. So you can see here in the right upper lobe, actually a cavitary lesion, so which is lined, so a bit of a cyst there. You can see some ground glass opacification and some actually frank consolidation over there. And then over here on the left side, you start to see these little holes. So you can see these reticular opacities at the periphery, so that's fibrosis. And you can see multiple layers of your small airways being tethered open. So bronchial ectasis, or to those of us who are simple like myself, honeycombing, right? Because it looks like a honeycomb. And then I think one other finding to note is that around the airways, so when we start to see areas of fibrosis, we want to know what's the distribution. So is it subpleural, which it is in this case, but there's also examples of peribronchiolar fibrosis, which changes your differential a little bit. This is more the middle sections of her cuts, and you can see this is a nice contrast in that study, as most people get in the emergency department. And then the only other changes, in addition to what I talked about, on the previous slide is her main pulmonary artery, which is much larger than the ascending aorta. So we don't diagnose pulmonary hypertension radiographically, but this suggests that something's not quite right. And then finally, the lower cuts where you can now see beautiful examples of what we call Talmage-King, who's one of the fathers of diffuse parenchymal lung disease. So Talmage-King honeycombing, so multi-layers and bilateral. So this patient clearly has advanced lung disease, advanced fibrotic lung disease. So just to round things up with her presentation, she had a profound leukocytosis. Well, this was not maybe that profound on admission, certainly high. Her white count was really elevated up to 60,000, and it remained that way for, right until transplantation, until we immunosuppressed her. I guess I gave it away. She got a lung transplant. Kidney numbers were fine. LFTs were okay, mildly hypercapnic. We eventually walked her, did a 6-minute walk test as a way to assess her exercise function. Not too bad. She's young. This was her echocardiogram, normal LV function, normal right ventricular function. There was no evidence of a right to left shunt. So when we talked about shunting on the earlier slides, forgot to mention that you can also have cardiac shunting, right? So extrapulmonary shunting. She did not have evidence of that. As I'm sort of giving away, she ultimately started getting worked up for a lung transplant. These were her right heart cath numbers. So mean pulmonary pressures are elevated, moderately elevated at 35. Normal being 15 to 20, transpulmonary grading to 25, so suggesting that this is a pre-capillary pulmonary hypertension that she has. Pulmonary vascular resistance of around 5.4, normal being around 3. So to summarize her presentation, 24-year-old non-smoker, now with progressive dyspnea and hypoxemia for several months, now presenting with advanced fibrotic disease and secondary pulmonary hypertension, so group 3 pulmonary hypertension, presumably. So well, let's think for a minute about our interstitial lung diseases. Again, this can be a whole talk in its own right. And I know this causes many people, including some pulmonologists, to cringe. But I think it's helpful to just go through this. So one of the main causes of interstitial lung disease are idiopathic interstitial pneumonias. The main one being idiopathic pulmonary fibrosis, although that's a disease that we tend to see in older patients, so generally in their 5th to 6th decades of life, which clearly she's not that. And then we also break it up into smoking versus non-smoking related. She was a never smoker, so we're not generally thinking about things like a respiratory bronchiolitis. Number 2 cause in terms of frequency of interstitial lung diseases are autoimmune related or connective tissue disease associated ILDs. So certainly patients with underlying rheumatoid arthritis or some of our vasculitides can certainly have lung manifestations. And then number 3 cause, what we see is hypersensitivity pneumonitis, so an extraalveolar allergic response. So yeah, so basically an allergy in the lungs that leads to fibrosis. And then you have sort of your grab bag of other rare lung diseases. Now, why does this matter? Well, clearly she has advanced lung disease, but if we identify this earlier on, let's say in an ambulatory setting, and maybe a patient's not yet on supplemental oxygen or they're requiring maybe 1 or 2 liters, there's a chance that you can treat the patient and either stabilize them or in some cases even potentially cure them. And so if somebody has idiopathic pulmonary fibrosis, we could consider starting them on antifibrotics like nintedanib or Esbriet. And in fact, now about 10 days ago, that we have a third drug, antifibrotic, nerandomilast. So that's exciting news for the pulmonary fibrosis community. If somebody has smoking-related interstitial lung disease and they're still actively smoking, then smoking cessation would be important. We still use steroids for certain conditions, especially COP or BOOP. If you're older like me and enjoy saying BOOP. Certainly, if you have a connective tissue disease, then treatment is based at treating that underlying disorder. So anti-inflammatory diseases, disease-modifying agents are certainly the first line, although now we are also using antifibrotics for that. And certainly if you have lymphangioliomyomatosis, there's in the last 10 years evidence showing that people can respond nicely to mTOR inhibitors. So again, important to understand what the underlying disease is, so you hopefully you can treat it. Obviously, in Biz's case, she's fairly advanced. So the question is what does she have though? Why is a 24-year-old presenting with advanced lung disease? So what's the differential for that? In her, I would put a connective tissue disease, associated ILD at the top, just based on her rate of progression, where she was fairly asymptomatic to now a matter of months, presenting with advanced lung disease. I would put dermatomyositis and MDA5 dermatomyositis generally at the top of that list. There are other vasculitides, certainly rheumatoid arthritis is possible, and you can certainly have overlaps of these. It's not unusual for her, especially with her age range, to present with an inherited disorder, so a MUC5 mutation that could then give you a UIP-like presentation. And then HP, although there were no known exposures that she had. And then generally not a primary cause of interstitial lung disease, but we always invoke reflux disease as contributing. She didn't have any symptoms of reflux. All right, so here's the big reveal. We checked rheumatologic labs. Her rheumatoid factor was, in the 1300s. Her CCP was greater than assay. We did send off an HP panel that came back weeks later. That was negative, and her myositis antibodies were all negative. So certainly seems like she has rheumatoid arthritis associated ILD. So unfortunately, Biz got much sicker. So she was hospitalized. I mentioned by the time she made her way to the ICU on day one, she was already on Optiflow, 70%, 50 liters. It generally takes us, we can probably evaluate somebody within 3 days and get them active on our list. But she just progressed. And so she required ECMO as a bridge to transplantation. Again, that's another talk in its own right. I'm happy to come back and speak about that. That's a topic that's near and dear to my heart. This is not Biz, but another patient. And just to show that she's active on the list, and therefore we want her awake and we want her ambulating. And that's exactly what she's doing. You can see her ECMO cannula there, the circuits behind, and so forth. And then I just put up this reference. Matt Bickett is one of my mentors and probably has the longest and most thorough experience of managing patients ECMO bridge to transplant. So this is the Columbia's 9-year experience with that. So encourage you guys to read that. So she was on ECMO as a bridge to transplant for about a week. Was actually crashed onto it, was that sick. Eventually got a bilateral lung transplant, and this is her immediate post-operative film. You can see better than her initial chest x-rays, although not normal, right? And so you can see some hazy opacities there. And certainly one of the issues that we deal with is primary graft dysfunction. People, when you're trying to pry out those old lungs, they can bleed, and she certainly did bleed and required some blood products. So that can lead to taco and trolley and whatnot. So fairly normal x-ray, quote unquote, normal x-ray for what we see on post-op day 0. And I think what's missing here are ECMO cannulas. So she was actually decannulated from her ECMO immediately post-op. And she's one thing that I always like to do is make a guess as to what kind of disease somebody has. And then because we remove those lungs, we have explant pathology. Certainly she had pretty advanced disease. So it was actually unclassifiable. So if somebody's so fibrotic, so scarred, pathology sometimes doesn't help you. But I think with her history and obviously with her rheumatologic factors, they said consistent with autoimmune disease. So Biz is, she's a 24-year-old. I sometimes act like I'm 80. We kind of clashed personality-wise, but we became friends. And so she, I mentioned, likes to crochet, so she made these lungs for me. And I think that's a mea culpa. Maybe I'm okay in her book. I don't know. So a happy ending. Let's talk about lung transplantation now. So lung transplantation is actually a new field. And so it's really only about 40 years old. The very first lung transplant was performed in 1963 at the University of Mississippi in Jackson, Mississippi, by James Hardy and colleagues. These are some of the features of this patient. And if you kind of look at this, and I know Dr. Ramirez is kind of shaking his head here, patient had chronic kidney disease. He was a prisoner. He had cancer. So a lot of these things we would view as contraindications or at least high risk factors, although we are actually transplanting, again, some patients with cancer, although certainly not metastatic cancer. The donor was a donor of cardiac death, and actually nowadays about 90% of our lungs are donors of brain death. So this was actually, Dr. Hardy was ahead of his times. Remember, this was 63, so we didn't have calcineurin inhibitors. So the mainstay of immunosuppression for this patient was Imuran or azathioprine, prednisone, and then mediastinal irradiation. Yeah. The patient survived 18 days, which is 18 days longer than I think anybody expected. The fascinating thing, though, was what do you think the patient died of? Any guesses? Infection.
Also infection.
Yeah, so it was actually infection, and then that contributed with, especially with the antibiotic use, to progression of kidney disease. So both infection and advanced kidney disease. What he didn't die of, though, was rejection, right? And so certainly at first that led to many more. And now you can see that in the late 1980s is when the field of lung transplantation really took off. There are two reasons why it took 2 to 3 decades between the first transplant to when the field really started to blossom. I already mentioned one was the advent of immunosuppression. And then any guesses as to the other? Okay, quite crowd today. So the other was just improvement in surgical technique. So the really bane of existence was the anastomosis, airway anastomosis, and so early cases dealt with dehiscence, so they would fall apart. People would develop mediastinitis, and so it really took the surgeons improving that technique for lung transplantation to take off. And take off it has, right? So there's been an exponential growth. This is one of the last registry slides available. Nowadays, I think most people acknowledge that we're doing more than 5,000 lung transplants a year around the world. The majority of those being bilateral with double lung transplants, but we still perform about 10% of unilateral single lung transplants. And that's true around the world, and that's also true at my institution at Vanderbilt. This is a little bit of a busy slide, also from the International Registry, UNOS database, basically. And I want you to pay attention to basically this orange line here, the yellow line here. So this is looking at the people who are added to the wait list and what happens to them. So this blue line here are the people who are transplanted. So you can see that the majority of patients are transplanted within 6 months. And now actually average wait list time is closer to 2 months on the wait list. But you can still see that despite the growth in lung transplantation, about 15% or 13.3 really are still dying on the wait list, which means that there are just not enough lungs to go around. So what's causing this increased demand? At the turn of the century or millennium, really, the number one cause or indication for lung transplantation was COPD. Numbers followed by number two closely interstitial lung disease. And you can see that that's changed. So now about 2/3 of patients are being transplanted for interstitial lung disease. Now it's about 30% of patients who have underlying COPD. And then indications like cystic fibrosis are actually decreasing. And you notice that the cutoff for this is 2018. That number is now much lower because in 2019, we had the advent of new drugs like Trikafta, right, that have really stabilized and improved lung function for patients with cystic fibrosis. And then pulmonary vascular disease remains low because we've also had improvements in therapies for PH, especially multi-drug, drug combinations for PH that are keeping people away from the operating rooms. And we expect this to get worse, right? In terms of the number of patients, or the incidence of ILD is only increasing. This is a fairly recent paper published in Chest about 18 months ago. And this is looking at the prevalence of interstitial lung disease around the country. The orange color is about a 5% increase. Navy blue is a 15% increase. So I'm not exactly sure what's going on in Washington. They have a 15% increase over a decade. But you can see that all over the country, prevalence, or at least recognition, of interstitial lung disease is increasing, which means that our ICUs are going to be, and hospitals are going to be more populated, and hopefully the numbers, well, not hopefully, but the number of lung transplants are likely going to only increase. So why do we do lung transplantation? So this is a conversation that I have multiple times a week with house staff and with patients, and this is exactly what I tell them. So it's for patients with advanced pulmonary disease. So how do I define that? So it's a progressive, irreversible lung disease, and I added over the last 2 years irreversible because we're finding that we're now transplanting people with ARDS, especially COVID-induced ARDS, with the resultant fibroproliferative disease more and more. And one of the big questions is if you give them time, will that disease actually reverse itself? So that's one of the big key words here. So progressive, irreversible lung disease despite optimal medical management. So if somebody has underlying ILD, are they on antifibrotics? If they have pulmonary vascular disease, are they on pulmonary vasodilator therapy, et cetera, et cetera? And then the other big component is their expected 2-year survival less than 50%, right? So it doesn't really matter what disease somebody's coming to you. If you have memory issues like I do, all you have to remember is if their expected survival is less than 50% in the next 2 years, think about lung transplantation. And then why do we do it? So what's the benefit of lung transplantation? And we basically achieve two things. So one is an improvement in quality of life, and the other is an improvement in survival. And studies show that we're able to achieve both of those things. This is an older study now from Jonathan Singer and colleagues from UCSF looking at quality of life improvements following lung transplantation. So they performed assessments in terms of trying to objectify quality of life. So this is an example of the physical function of a short form 36. So they measured it right just before transplantation, and then they measured it at intervals after lung transplantation. This dashed line here is the minimal clinically important difference. So all you have to do is achieve this difference, and transplantation had a significant improvement in your quality of life. And you can see that just within 6 months, that's almost tripled. So a very clear improvement in quality of life that really extends for at least 3 years, which was the duration of that study. So again, we can improve quality of life with transplantation. How about survival? This is a pretty old study, but one that I like. And so this is looking at 25 years of UNOS database data. And it's looking at all different kinds of organs. So I'm going to, of course, draw your attention to the lung one here. And they looked at patients who were added to the wait list, but for whatever reason, not transplanted. And then they also looked at survival for patients who were transplanted. And you can see that for those who were added to the wait list but not transplanted, median survival is about 2 years. And that's where we get that 2-year number, right? Because if somebody's going to live for greater than 2 years, then transplantation is just not going to be worth it. Patients who were transplanted at this point in time had a median survival of 5 years. So we kind of say that at that point, transplantation can afford a survival advantage of about 3 years. One more pause. You notice here that median survival for the lungs, 5 years, kidneys, 12 years, liver is about 12 years. Why the difference? Why that drastic difference in median survival?
The lung is attached outside the infection.
Yeah, exactly. So you're breathing in dust, you're breathing in microbes. So there's this constant upregulation of innate immunity and then subsequently adaptive immune responses. And that is a trigger for chronic lung allograft dysfunction. And so that's the theory.
It's just not going to reason be that the primary process that took out the lungs in the first place didn't go away. So your young lady, the 24-year-old with rheumatoid, why wouldn't you get rheumatoid lung again?
Yeah, that's a great question. And there was a lot of concern about that in the field. We don't see recurrence, and so one potential reason is that we're just using high doses of immunosuppression, and maybe that's quelling the inflammatory process, the systemic inflammatory process. A pessimist might say, well, if average survival is about 5 to 7 years, maybe these patients are dying from CLAD, chronic lung allograft dysfunction, before there's even a chance for the systemic process to attack their lungs.
That's a good point. It took her 24 years to get.
Yeah. So I mentioned this is an old slide, so median survival is improving. And so this is looking at different errors in lung transplantation and outcomes. So median survival, as I mentioned, in the oldest error study here is about 5 years. And now we're seeing that conditional survival or median survival is now approaching 7 years, or 6.7 years to be exact. And we attribute this to a few things. So one, our surgeons are better at their surgery, implantation technique. Medical doctors like Dr. Ramirez and myself like to pat ourselves on the back, and we are keeping our patients alive. We're better at identifying donors. So what makes a good lung donor, and how do you preserve those lungs between the time they're procured and implanted? We're also better at selecting recipients, right? Not everybody who walks in our doors is going to be a good lung transplant candidate. Now, the one thing that I'm going to ask you to reflect on is these curves are fairly similar, right? So where they really differ is within the first year or two of transplantation. And to me, that suggests that the improvement in survival is as a result, or results from the fact that we're doing something differently in those 1 to 2 years to help people live longer. But after the first 2 years, we're really not impacting causes of death. We're not impacting mortality. So what happens within the first 2 years versus what happens afterwards? So this is another slide from the International Society for Heart Lung Transplant Registry. So if somebody were to die within the first year of transplant, so to the left of this black arrow, number one cause is the development of infection. And this is non-CMV.
Sit down, sit down, sit down, sit down, sit down.
Somebody's dog is misbehaving. If somebody were to die after the first year, the number one cause of death is CLAD, or chronic lung allograft dysfunction. So what is CLAD? Forgive me for the graphics I created that long ago. Thank you. So, but this is the normal airway, and then your alveoli that surround it. So it's nice and pink, healthy or initially. And then in terms of a theory as to why CLAD happens, well, maybe you have acute injury event. So whether it be infections, whether it be acute cellular rejection or antibody-mediated rejection, perhaps that, and there's a list of a lot of acute injury events that our patients have occurring to them. All of those acute injury events cause an influx of inflammations, right? So you can see all your pro-inflammatory cytokines and mediators. And if that happens enough, and so the analogy that I use is I'm a clumsy runner, I'm running, I trip, skin my knee. Fine, after one event, that heals, it scabs, but then eventually heals. But if this happens repeatedly, 5, 6, 7 times, eventually I'm going to have a scar that forms. And that, I think, is what happens, right? So you have eventually an influx of pro-fibrotic pathways that can then result in fibrosis of your small airways or bronchiolitis obliterans, or what we're recognizing now in the last decade or so is scarring of the parenchyma as well. And suffice it to say, there are things that we can do to try to delay the onset of CLAD. So we can augment immunosuppression, we can start anti-inflammatory drugs like azithromycin, but there's no cure for CLAD or chronic rejection. And so really our work as transplant pulmonologists is to either address risk factors for CLAD or try to identify it early enough, because again, there are just no treatments for that, although there's a lot of work being done to identify the treatments for CLAD. I do have one quick title change up there, and that's because I presented one theory of CLAD being this accumulation of injury events. But what Dr. Ramirez and myself often see is we have patients who do fine. They have acute cellular rejection, maybe 2 episodes, they have some infections, but their lung function's stable. And then suddenly one day they maybe get a viral infection and everything plummets in terms of their lung function. So another theory potential is it a failure to recover from an acute injury event that predisposes to CLAD? The answer is I don't know, but kind of frames how we study this disease. So CLAD prevention, so either prevent acute injury. So if somebody's at risk for reflux, we consider things like a Nissen fundoplication, right? Fairly draconian, but effective. And then if somebody has acute injury events, we promote recovery. So we tend to use a lot of steroids, especially after acute infections, to try to calm down the inflammatory milieu. All right, so let's move on. So again, this is an internal medicine grand rounds. And so one of the things that are more relevant to you guys who don't necessarily see lung transplant patients in clinic is when can you recognize somebody with advanced lung disease that they might benefit from lung transplantation, and when can you refer them to Dr. Ramirez and his team? So I mentioned when we think about patients whose expected survival in the next 2 years is less than 50%. And so when we talk about referring, keep that number in mind, and that's apropos to several diseases. I'm going to focus just on 2 main classes of disease, just for the sake of time. So again, number 1 indication for transplantation is ILD. So when do you refer somebody? Well, this is a famous figure published in 2011 by Talmadge King and colleagues showing the progression of patients with interstitial lung disease. And these are generally thought to be patients with advanced fibrosing alveolitis. So our interstitial, so our UIP or idiopathic pulmonary fibrosis or fibrotic NSIP. Although take that with a grain of salt. So we know that there are kind of 3 pathways in which patients can progress. So you can have some people who within 1 year of diagnosis are dead. And maybe those are those patients with, I mentioned dermatomyositis, especially the MDA5 variants. You have other people who have this kind of slow progression. And so they're alive maybe even 10 years after the diagnosis of their disease. And to me, that really makes you question, did they actually have UIP or fibrosing NSIP to begin with, versus was it another type of interstitial lung disease? And then the other way that people can progress is they have kind of a slow decline, and then boom, one day they have some sort of trigger and they have an acute exacerbation, they end up in an ICU. That's associated with an 80% mortality. If they do survive that, then maybe they stabilize until they have another episode of acute exacerbations. Just as a side note, I mentioned that we have antifibrotic drugs. They don't reverse disease, they maybe stabilize
With
disease.
Anil, the one that stands next to the sixth grade bathroom.
And some of the best evidence is that these drugs are really efficacious in terms of preventing these acute exacerbations. So we even start them fairly late. So how do you prognosticate somebody who's walking to your clinic with advanced lung disease? How do you know they're going to be stable for the next few years or not? One of the things that you can do is just look at lung function testing. So this is from a group in London looking at over 100 patients, and they looked at baseline pulmonary function testing and then also trends in pulmonary function testing. And they divided people into both late deaths and early deaths. And you can see that there's a clear difference in these characteristics. So those who were dying early had a forced vital capacity of less than 80% of predicted, so closer to 60% of predicted. Diffusion capacity was less than 40% of predicted in the early death group. And then these patients were also more hypoxemic. So these are some of the criteria that we use in terms of thinking about when to refer somebody for transplantation. Trends are also helpful. So this is looking at patients who either had stable diffusion capacity over a period of time versus those who had a decline. You can see that there's, if you had a decline greater than 15% in a 12-month period, that predicted mortality. So that's one of the things that we look at. Another is just changes in function. And this is actually one of my favorite studies because it's just so simple. So this is from the Michigan group. So they looked at the prognostic ability of changes in your 6-minute walk test, so desaturation. So they walked patients, so they walked them for each minute. And then they, I guess, performed calculus and looked at area under the curve. So if somebody started off at 100% and then in their first minute dropped to 98%, you got 2 points. If they dropped further, then in the next minute to 94%, then you got 6 points. And they tabulated that. And basically, if your desaturation area was greater than 10, then that was associated with mortality. So it has a ratio of 1.3 with a significant p-value there. So simple tools that you can use in your clinic. And we have a lot of outreach clinics that we go to that don't have resources, but I have my little hand spirometer and I walk the patients. And if they desaturate, then I tend to push them through the evaluation phase more so. And then certainly if somebody has an acute exacerbation, if you saw them in the ICU, if they're not dying from that, certainly think about an expedited evaluation. If they survive to discharge, that patient should be evaluated ASAP. So this is consensus guidelines from the International Society for Heart Lung Transplant. When to refer for transplant, you only need one of these indications. And then this is when we actually list patients for transplantation. So again, just more advanced criteria. And I think you guys will have access to these slides. So certainly take a look at this. What we tell people though is refer early, right? So even if somebody just has an ILD, just refer them because there are things that we can do. You can, if our patient was recognized to have this disease early, she could have been seen by rheumatology. We can, a lot of our patients are overweight or underinsured or don't have caregivers, or maybe they're actively using substances like tobacco or drinking. So this provides time to optimize the patient for transplantation. And then, there are lots of different clinical trials available in the interstitial lung disease realm. And so we always encourage patients that they consider those clinical trials. I'm going to take a sip of water. Questions on ILD and when to refer. All right, let's quickly move on to COPD. So when should you think about referring somebody? How do you prognosticate in COPD? Probably one of the best methods is using our BODE index. So I was fortunate enough to be trained by Bart Celli. He created this simple tool. So he looked at 4 parameters. So B stands for body mass index. Remember, advanced COPD is a catabolic state, right? It's highly inflammatory. So a lot of these patients are so hyperinflated that they can't eat. So they're losing body mass. So if your body mass is less than 21, that was a poor prognostic indicator. Degree of airway obstruction, and I'll show a slide or two on that. Dyspnea, so you can actually rate levels of dyspnea. There's a simple score that you can Google. So can you walk on flat ground 100 yards, or do you have dyspnea just putting on your clothes? And then also the degree of exercise in terms of actual distance. So you can put this all together, and he certainly did this in a cohort. So you derived this in a cohort of 200 patients and then validated in a separate cohort of 600 patients. And you can see that there's clear separation of your curves. So if your BODE index is closer to 7 or above, then those are patients who are likely to die within the next 3 years. And so those are the patients that we should refer for lung transplantation. How about those patients who have frequent exacerbations of their underlying COPD? Well, we know that acute exacerbations can make lung function worse, but they're also associated with mortality. I won't go through all the details here, but A are people in a year's period who had 0 exacerbations. B, they had, I think, 1 or 2 exacerbations. And then the C arm are those who had, I believe, 3 or more exacerbations. And you can see significant separation in these curves. So if you have somebody who has repeat exacerbations, certainly send them to Dr. Ramirez or your friendly transplant pulmonologist. Now, asterisks though, because there are therapies that we utilize to decrease the exacerbation frequency. So we have good drugs like roflumilast that have been shown to have a significant decrease in your number of exacerbations. And then good old-fashioned azithromycin, due to its anti-neutrophilic properties, in this New England Journal trial, also showed to decrease the number of subsequent COPD exacerbations. So first step, try to decrease your exacerbations. And then if that fails, then certainly refer to your transplant pulmonologist. And then there are some therapies. So remember, we're prognosticating. The NET trial was looking at the role of lung volume reduction surgery as a benefit. And there is a role for that, and we'll talk about that in just a second. But there was this high-risk cohort where the patients died quickly, and eventually they changed the indications for the NET trial. So patients who had an FEV1 less than 20% and either a diffusion capacity of less than 20% are predicted, or homogeneous emphysema fared worse. And so again, if you have somebody with COPD with a low FEV1 and DLCO, then maybe thinking about transplantation sooner is a good thing. So when to refer, I've summarized there. So if your BODE index is 5 to 6, you have progressive disease, not a lung volume reduction surgery candidate, then you think about referring. And these are the indications when a transplant pulmonologist would consider activating somebody onto the wait list. Just a little aside about advanced COPD care. There was a lot of debate early on about the role of transplantation for COPD, because patients generally don't die right away like they do in ILD, right? So most of you have had patients who have COPD, even advanced COPD for a decade or even longer than that. And so for people who really have severe disease, sure, there's a benefit. But there are other things that we can look at. So I mentioned lung volume reduction surgery. So generally smokers have more emphysema in the upper lobes of their lungs. So you can actually remove those and impact exercise function and quality of life. We now have less invasive means of bronchoscopic lung volume reduction surgery, or basically just placement of one-way endobronchial valves, and then conference of the week, where we have representatives from each of these disciplines in one room talking about the best therapy for patients with COPD. And sometimes it's just better medical management. Sometimes it is surgical lung volume reduction. So it's a nice thing that we do. How much time do I have? Oh, 5 minutes. Okay. Let me talk about risk factors real quick, and then we'll end there. But I think the field is changing from going away from absolute contraindications to thinking things about more of risk factors, because a lot of these things have changed. So before we would transplant patients with cirrhosis. Now it's, well, unless they have severe portal hypertension. Now we think about multi-organ transplantation. So I wouldn't necessarily disqualify somebody from a transplant. Leave that to a transplant pulmonologist, because the field is actively changing. We do transplantation now for HIV, hepatitis C, even frailty, right? Because people can recover from their frailty. BMI is also a moving target. So before, our center had a strict cutoff of 30. Well, evidence shows that now your risk really doesn't increase until your BMI threshold is greater than 35. But we're pushing that barrier even at Vanderbilt, because it's not like your predicted risk is increasing that dramatically, even above 35. And then age too. So we know that lots of studies suggest that advanced age patients do worse. So this is looking at the impact of center volume and advanced age. So these bottom lines are patients who are greater than 70. These are patients who are less than age 70, clear separation. But we would argue that if you select a patient, an older patient, well, then they're likely going to do okay from their transplant. And this is looking at outcomes for patients who were transplanted and why they died. And you can see that the majority of these patients died from non-pulmonary reasons, right? So cardiovascular disease, malignancy. So if you select your patient well enough, you can certainly have good outcomes. So I think I'm just going to end there. Happy to talk afterwards about some of the research that we're doing at Vanderbilt. So hopefully in this last hour, so I'll do my cardinal minute here. We hopefully have convinced you that lung transplantation is now an acceptable therapy for lung disease. And certainly we've evolved as a field over the last 40 years. We're transplanting more. What I've shown is outcomes are much improved with an improvement in median survival of 2 years and improving more so. And then hopefully you'll leave today with a better idea of when to refer somebody for lung transplantation. So remember that somebody with an advanced lung disease, which is a progressive disease, an irreversible disease, despite being on optimal medical therapy, and their expected survival is less than 50% in the next 2 years. So I thank you for your time. Again, don't hesitate to call if you have questions. Certainly reach out to Dr. Ramirez at your institution. He's again a wonderful partner, and I'm grateful for that. So thank you.
So the chair always asks the first question. Is this fascinated with the idea of just because it was recently announced that Kentucky is no longer number one in the country in lung cancer deaths. We're now number two. Great. How many of our patients can really be affected, and how did you I mean, you couldn't use like FDG PET, make sure that you didn't have the smallest micro metastases. How would you go about trying to make sure that you're doing the right patient at the right time for transplanting for malignancy?
Yeah, that's a great question. So I think first of all, the concern about malignancy is that if you do transplant somebody and they're found to have malignancy, certainly with immunosuppression, and we induce people with immunosuppression to begin with, so they're really immunosuppressed within the first few weeks and months. That certainly you're creating an environment for cancer metastases and growth. One of the things that remember, our risk factors for advanced lung disease are mainly smoking. And so every now and then we find on explant cancer, right? So we've now transplanted somebody who has cancer. And there was a recent publication, we were talking about this last night, that showed that outcomes are absolutely fine. And that there isn't increased death or cancer recurrence because you've cured a stage 1 cancer. You've done the surgical removal. And so that evidence has kind of pushed people into the field for considering transplantation as a therapy for cancer. Older studies have shown that eventually there is going to be recurrence, generally around the 5-year mark. But there are pioneers at Northwestern who are now looking at this again, and it's certain kinds of cancer, so lipidic adenocarcinoma. Certainly, if it's in the mediastinum or beyond outside the thoracic cavity, we wouldn't view them as a candidate. But if it's confined to the lungs and you're removing those lungs or explanting those lungs, you're washing out the field really well. Some people even wash out the cavity with chemotherapy. Then recent studies have shown that the patients can do okay. Now, that field, the resurgence of that field is new, so there's not a lot of great literature yet, either from the Northwestern group or even from our group. We've done 2 of those patients in the last 2 or 3 years. But it's certainly promising.
So it sounds like the key is that if you get a 5-year survival and the transplant itself is 5.2, that it's going to actually look pretty good.
Yeah, so that's one of the arguments. Median survival now closer to 7 years. But if you're transplanting, let's say, a 75-year-old, would we expect them to live 7 years? Maybe not. But is it a bad thing if they still live 5 years or 4 years, right? Especially if it's good quality years. Then triple. Yes, exactly. Yes, ma'am.
So I know it's obviously not ideal to transplant people when they've crashed on ECMO. Is there any data about do they tend to also kind of meet that 5-year mark, or do they have lower survival?
Yeah, so in that Bacchetta paper that I highlighted it there, the big thing is when you put somebody on ECMO, understanding what's your exit strategy, and are they a decently good candidate? Are they actually an active candidate on the transplant list? So then we're truly using ECMO as a bridge to transplant. Sometimes, though, we don't really know. They haven't had time to undergo the evaluation, so we put them on as a bridge to decision. And you're taking a risk, right? Because then what if they get their left heart cath and they have triple vessel coronary disease? You're not going to transplant them. That's an institutional decision. We do it. We don't like to do bridge to decisions, but we do. All that to say is if you put somebody on, generally the numbers are getting better. It used to be about 50% survival to transplant. Now it's closer to 80% survival to transplant. If they are successfully transplanted, though, long-term survival matches those who never required ECMO as a bridge. Yes, sir.
So I'm a rheumatologist. So one difficulty we have as a rheumatologist when we get consulted in those ILD cases with the positive antibody of something, some of those cases, they are clear, they are whatever autoimmune disease, but some of them just an isolated antibody. And then if I go to like our diagnostic criteria of that certain disease, but there's nothing there. For example, just isolate like SSA antibody or maybe just high CCB, but without having the actual rheumatoid arthritis like picture. And as you presented, the treatment is different between like, there's ILD, then with like autoimmune disease, then you treat the baseline disease, but if not, then it's different treatment. So any suggestion from your side as pulmonologist, like in those cases, it was just like isolate antibody, but not really the disease not there.
Yeah.
How you react to that?
Well, so there's actually a disease subset in there, so something called IPAF, and I think we've now changed the terminology of that, but how I know it is interstitial pneumonia with autoimmune features. So it's exactly what you're saying. They have maybe some features, but they don't meet the rheumatologic society criteria for having, name your disease. How we manage those patients is not all that different. I think one of the things that I think I would try to pay attention to more so, though, is just ruling out systemic features of those diseases, so especially esophageal dysfunction, because we have a lot of esophageal dysmotility, especially if they have scleroderma-like features, and that can certainly impact lung function post-transplantation. So I think, does it affect prognosis in terms of survival pre-transplant? Maybe not. It's hard to know. But I presented that figure where everything's nice and classified. In reality, a lot of our interstitial lung disease is unclassifiable. So it's really just monitoring the patients and making sure that they're not progressing rapidly before you can get them to transplant.
We did have one question from online, actually from Dr. Christian Furman, who's our palliative medicine chief, and she wanted to know what is the role of palliative care.
Yes. So there's always a role, and I think this is it's complicated, right? Because a lot of our patients have advanced lung disease. They're short of breath. Their quality of life is poor, and I believe that their palliative care should be involved. And they can be involved, and you can still pursue lung transplantation, but they should be comfortable while pursuing lung transplantation. Unfortunately, I think a lot of people, even at our center, would view that involvement as, oh, well, maybe they're not serious about lung transplantation. And so, but I think we need to change that stigma. And then certainly after lung transplantation, but from the time somebody develops actual CLAD, chronic lung allograft dysfunction, generally they tend to progress over a period of about 12 to 18 months. And that period can be traumatizing, not only because they're symptomatic, but it almost triggers a PTSD state because they remember what it was like to suffer pre-transplant. And so I'm pretty quick, and my colleagues are pretty quick to involve palliative care at that point.